Thank you. So first of all, thank you for the opportunity to be here today. First of all, I think it's fantastic to see economics being at the heart of the debate for global public health. As Peter also mentioned, I've spent the last 8 years working with governments across different African countries. So I'm going to try to bring a bit of a practical perspective to supply chain and what the realities are on the ground and why this may be an area for increased funding needs today and also going forward. So I want to start by telling you a story about Amina. Amina is a nurse in northern Nigeria in Sokoto. She has been working in this clinic for 15 years. She's roughly seeing 50 to 100 patients a day. She gets in at 7 p.m. and is quite frankly, exhausted, overwhelmed, etc. Now, one of the biggest challenges that Amina has in her day-to-day work is that most of the time there's no products available. So she has patients coming into the facility and she has to turn them away. Now, the reality is that this clinic, as many other clinics in northern Nigeria and other parts of African countries, are supposed to receive these commodities on a regular basis, but she doesn't. And so her reality is for vaccines. She can only provide vaccines every Wednesday. She doesn't have a functional fridge in her facility. So she gets up 7 a.m., gets on a bus, takes 1 hour to go to a larger city. In that city, she picks up the vaccines, put it into her little cooler box, gets on the bus back to the facility. All of these costs she pays herself. It's typically 100 naira per way, so it's 200 nairas. So by the time she's back at the facility and she's actually able to start seeing the patients, it's now like between 9 or 10 a.m. So there's been mothers waiting with their children in the waiting room since as early as 6:30 a.m. in the morning. Now, at the end of the day, of course, she doesn't have a functional fridge in her facility. The rule is that she's supposed to go back to the larger facility, drop the vaccines, and then come back. But quite frankly, most of the time, she's too tired. So she ends up throwing it out with the normal trash at the back of the facility. Then there's the reproductive health commodities. So she's supposed to provide these services on a daily basis. Every month, she has to go to a meeting in the big city again. She has to bring her little book, which is a specific book with all the details about how many patients she's seen, how many commodities and which commodities she dispense to which patient. When she's there, they then try to do a little bit of quantification together. The reality is that most of the time, she gets the same amount of commodity that she got last month. So she sometimes wonders, why do I have to sit and fill in all this paper trail? Now, at least they pay her bus fare, and she gets a little bit of refreshment, and she goes back. So that she has to do on a monthly basis for the reproductive health commodities. HIV and TB. This is quite easy for her. She does wonder how much money donors have, because essentially, there's a very nice truck. It arrives every 2 weeks. It has the HIV and TB commodities. The donors gave her a little computer. It's in her office. There she puts the specific commodities that she's been using in the past 2 weeks into the computer, and then they decide how much she gets. So she's not really part of the decision-making progress, but at least it's arrived at her doorstep. Then there's malaria, the nets. They typically arrive 1 or twice a year, but it's a campaign. It's in the MNCH week. She doesn't have anything to do with it. Really, the communities do it, the NGOs that work in those communities. And so she doesn't spend much of time thinking about it. Essential medicines. This is what the government is supposed to deliver to her every month. She hasn't seen a truck for the last 3 years. So her and the other nurses that are working in the facility, they've decided to develop a revolving drug fund. So they put a little bit of money in there, and then they go out and they buy some products, and then they actually have to charge the women for coming in to getting products and seeing the nurses, which they're not supposed to do. Sometimes they hand out the products because they know that the mother who's coming with the child can't afford the products. Also means that they run out of money. And so often they have to turn around or turn away the patients. And she knows that they mean that they have to go out into the community, sometimes buying substandard products, and often not buying anything because they don't have any of the money to buy it. And then there's the emergency. when polio came a couple of years ago Ebola came a couple of years to Nigeria, all she did was actually just praying that it wouldn't hit her little community, because she had no idea what she was supposed to do if it happened, whether there was any products she was supposed to give to patients or not. So she doesn't know what to do in case of an emergency. Nobody has ever told her or her colleague anything about that. Now, why am I saying that? I think, there's a Nigerian author, Chimamanda Adichie, who said, we need to avoid falling into the trap of the single story. And so it's very clear that this is one story, one particular story about one nurse in one particular country in Africa. So it's not representative of what's happening on the continent. However, I think we hear these stories more often than not. And if Amina was to sit down one day and actually try to draw out all these various different supply chains that are coming into her facilities, it would look a little bit like this. So this is a string of vertical supply chains covering all the products I went through, or the disease programs I went through before, all making their way down to the facility in many different ways. And we're leaving a lot of this complexity to the people working in the facility trying to manage this. Really, it's in a country like Nigeria, we're talking almost 30,000 facilities, over 20 different data systems, 12 different major donors that are funding all of this, and the list in terms of complexity goes on and on and on. So it's a quite complex when you get into the economics of it. Like, how do you actually even start costing something like this? And who does this type of costing? Most of the time, people don't, and it makes it very difficult to do the arguments for why you could actually strengthen and why we need to overcome these economic bottlenecks. So the case I want to make is a case for incorporating a little bit of what I call a human-centered approach in costing these economic bottlenecks. And so why do I think that? Well, as the story of Amina was just exemplifying, each of the people who are in these healthcare systems are facing a range of economic bottlenecks in making sure that these products are available at the last mile. And often when we think about the costing of the supply chains, we take a very high-level systematic approach and say, okay, well, you need a truck, you need to put fuel into the truck, and then you need a warehousing and so forth and so forth. But often what we forget is the economic cost that the people who are in the system are actually facing. So I put this into a couple of buckets. There is one, the healthcare workers. So we talked about this with Amina. And so these are the out-of-pocket payments that we're asking the nurses, the doctors, the health extension workers at the last mile to carry, to go up to the level above them to pick up these products. It can be $1, $2, $3 per day. But where are they supposed to get that money from? Often they find it out of their own pockets, their own salaries, or they go to the patients and they charge those patients so that they can make the trips. The second cost, of course, is that those are skilled healthcare workers. We know we don't have a lot of them, and they're supposed to be seeing patients. And so there is an opportunity cost in all these skilled healthcare workers not seeing the patients while they're on the bus. The second one is the patients themselves, of course. Sometimes they're spending a lot of money going to the facility. They're waiting hours to see a nurse or doctor, to be turned away and being told that the products that were supposed to be available for free to them isn't there. So they lost that time in terms of labor, income, and so forth, and also spend money out of pocket getting to the facility and then having to go back into the private sector and buy these commodities. There's the supply chain managers themselves that are sitting at higher levels within the government. Often they are making phone calls using their own cell phones. The operational costs are not available to a day-to-day basis. Many of them are actually using their own money to sponsor the operational funding while they're waiting for money to be released from governments, because the budgets aren't there necessarily for supply chain. Many countries you go in and you ask, what is your supply chain budget? You can't pull out that particular budget line. And so they always have to go and advocate for operational funds to be released. And they cover those economic costs, no interest rate paid back or any of that thing. And then, of course, you have the program officers for each of the various disease programs that are carrying a lot of costs themselves. So as we think about this human-centered costing approach to supply chain, what am I talking about? Well, what I'm talking about is a little bit like the iceberg. There are the costs that we see on top. And so these are the warehousing costs, the fuel, all the typical stuff. But then there are all the things below the surface that if we don't cost those and if we don't focus on them, we're likely to get systems that are non-performing, stuck out, wastages, etc. And so the argument I want to make is that the things that are above the surface, that's typically what a minister sees. So as we're having conversations with countries, we're asking them, how much are you spending on supply chain? These are typically the costs that they will be citing, and they're often not very large, to be honest. It doesn't cost that much to rent a warehouse and a little bit of fuel and truck. What it really costs is all the things I was just talking about as we go down and look at all the hidden costs that a human-centered costing approach would start to unveil, as well as all the costs that are not being seen by the minister, which is, you're supposed to do a monthly delivery, you're only doing a quarterly delivery. Now, as we think about potential redesigning the system and reducing these economic bottlenecks, the kind of figures that we come up with when we say, let's integrate all the supply chains, etc., the reality is that those costs are often a little bit higher than what the minister sees. Often, they're lower than the real cost of what the system is today. But if we are not able to pull out and distill these various economics costs, it makes it very difficult to have conversations in country about investments and about reducing some of these economic bottlenecks that, in particular, the people who are working in the system are facing. So what could reduce these economic bottlenecks in terms of some suggestion? So for the first thing is this sort of zero-based budgeting, including a human-centered costing approach, and really going bottom-up within these countries and understanding, as the system design is laid out today in terms of the number of zonal stores, district stores, etc., how much is this system actually supposed to cost if you were to run it the way it is? And what are all the various hidden costs that are in the system and who are carrying those costs in the system today? To create a much clearer and more accurate baseline in the countries. The second one is, of course, around integration. Integration between the various supply chains, and many of them are supply chains that are being setting up by different international agencies within these countries. Thirdly is outsourcing. In many countries today, most of these supply chain operations are still housed within the ministries. If you look at the private sector, all of them would have it outsourced. And we know from different facts that you can probably reduce the cost by 5 to 15% by actually starting to outsource. That has a lot of implications from a government perspective, which makes it not an easy conversation, but it does allow you to overcome many of the economic bottlenecks I laid out before in terms of doing last mile distribution all the way directly to the facility and avoiding having nurse spending time in the bus going up and to pick up the products. The last one is, of course, data. Our ability to try to create one data platform instead of having different books, different data systems being installed at the facility level and also at the central level. So I'll stop very shortly. Just two more things I wanted to make a point on. In terms of the cost saving, we did in one state in Nigeria quite detailed economic study of how much can you actually save. And so this is across 1,200 facility in this particular state. And we looked across the big 5 donor programs. Now, the first thing is that not all the facilities are delivering all the healthcare services. So first one needs to get a very clear sense of what are the different healthcare programs that are being offered at each of the different facilities. Then we looked at the various overlaps. And so what we saw, there was sort of only 12% of the facilities that were actually offering all the 5 programs, then 48% of the facilities that were offering 3 to 4 of the programs, and then 40% of the facilities that were offering between 1 or 2 of these programs. Today, in this particular state, there will be a separate vertical supply chain for each of these single products that have a particular economic cost. When we looked into what we could save by integrating all of these supply chains and having one truck, one warehouse, one truck going around to all the facilities, we were essentially looking at close to $600,000 for one particular state in Nigeria. And with some very, and I should say this since I'm amongst very distinguished economists, very rough back of the envelope calculations, if you take and extrapolate that to the rest of the Nigeria, you're looking at close to $10 million a year that you could be saving from integrating just on the donor programs, and that's without integrating all the essential medicines. So the last point I want to make I was probably supposed to speak a little bit around emergency supply chain. And I did speak with colleagues across different countries and said, tell me a little bit, how much do these countries spend on emergency supply chains? It's almost impossible to get a sense of what that number is. I did get a number of only $250,000 in Cameroon. That's a population of 25 million people. So that's roughly 1 cent per person that they were spending on emergency supply chain. So, my argument would be, wouldn't it be better to build strong foundational supply chains in these countries that then can be leveraged, both for the routine service that we need to provide on a day-to-day basis, and then also for the various emergencies if they may occur. And the last point I want to make, we're looking a little bit around, but what role can the international aid agencies play in this? Well, most of them are spending huge amount of dollars, probably up towards 60 billion on different healthcare commodities. But you're not seeing the same spending on the supply chains. If this was the private sector, in the pharmaceutical industry, you're roughly spending between 4 and 11% of your commodity value on supply chain. I think in the most African countries, we are far below that. If we were even to be slightly conservative and take 2 to 3% of that, we would be ending close to $1 billion that we actually have available to be strengthening these supply chains in the countries if we were to increase the collaboration across the various agencies. Thank you.
Thank you, Tania.